You keep coming back to that point about if you like what you have, you can keep it. Right. And I will return to that subject when we get to the issue of the public option and whether the government should be in the insuring business. But one of the things when we talk about the kinds of changes that may occur, the elderly are affected. Yeah. Medicare will be affected. 28%, 26, 28% of money in Medicare is spent in the last year of life. The elderly are very critically affected. Just a quick soundbite from a couple of people to lay out the parameters of the problem.
I'm Dr. Michael Jensen at the Mayo Clinic in Rochester, Minnesota. I see too many patients who have terminal illnesses or no hope of recovery who receive weeks or months of intensive care unit treatment only to prolong their death. I find this approach very distressing, and the waste of money is appalling. We just can't afford to provide all treatments to all people.
My name is Robert Wasson. My mother is 74 years old. She has terminal cancer in the stomach lining that has spread to the lungs. She deserves to be treated medically to the best of their ability. To say it's too expensive is not right. I just don't think you can put a price tag on quality time with loved ones, especially at the end of their lives.
And we have with us a couple of people who really represents the opposite ends on this spectrum too. I want to talk, if I can, to Jane Sturm, your mother, Hazel Homer.
Yes.
100 years old, and she wanted...
She's 105 now, over 105, but at 100, the doctor had said to her, I can't do anything more unless you have a pacemaker. I said go for it, she said go for it, but the arrhythmia specialist said, no, it's too old. Her doctor said, I'm going to make an appointment because a picture is worth 1,000 words. And when the other arrhythmia specialist saw her joy of life and so on, he said, I'm going for it. So that was over 5 years ago. My question to you is, outside the medical criteria for prolonging life for somebody who is elderly, is there any consideration that can be given for a certain spirit, a certain joy of living, a quality of life, or is it just a medical cutoff at a certain age?
Well, first of all, I want to meet your mom. And I want to find out what she's eating. Look, the first thing for all of us to understand is that we actually have some choices to make about how we want to deal with our own end-of-life care. And that's one of the things I think that we can all promote, and this is not a big government program, this is something that each of us individually can do, is to draft and sign a living will so that we're very clear with our doctors about how we want to approach the end of life. I don't think that we can make judgments based on people's spirit. That'd be a pretty subjective decision to be making. I think we have to have rules that say that we are going to provide good quality care for all people.
But the money might not have been there for her pacemaker or for your grandmother's hip replacement.
Well, and that's absolutely true. And end-of-life care is one of the most difficult sets of decisions that we're going to have to make. I don't want bureaucracies making those decisions, but understand that those decisions are already being made in one way or another. If they're not being made under Medicare and Medicaid, they're being made by private insurers. We don't always make those decisions explicitly. We often make those decisions by just letting people run out of money or making the deductibles so high or the out-of-pocket expenses so onerous that they just can't afford the care. And all we're suggesting, and we're not going to solve every difficult problem in terms of end-of-life care. A lot of that is going to have to be we as a culture and as a society starting to make better decisions within our own families and for ourselves. But what we can do is make sure that at least some of the waste that exists in the system that's not making anybody's mom better, that is loading up on additional tests or additional drugs that the evidence shows is not necessarily going to improve care, that at least we can let doctors know and your mom know that, you know what, maybe this isn't going to help. Maybe you're better off not having the surgery, but taking the painkiller. And those kinds of decisions between doctors and patients and making sure that our incentives are not preventing those good decisions, and that the doctors and hospitals all are aligned for patient care, that's something we can achieve. We're not going to solve every single one of these very difficult decisions at the end of life, and ultimately that's going to be between physicians and patients. But we can make real progress on this front if we work a little bit harder.
Is that a conversation you could have had with your mom?
What I wanted to say was that the arrhythmia specialist who put the pacemaker in said that it cost Medicare $30,000 at the time. She had been in the hospital 2 or 3 times a month before that, so let's say 20, 30 times being in the hospital, maybe going to rehab. The cost was so much more, and that's what would have happened had she not had the pacemaker.
Well, and that's a good example of where if we've got experts who are looking at this and they are advising doctors across the board that the pacemaker may ultimately save money, then we potentially could have done that faster. I mean, this can cut both ways. The point is we want to use science, we want doctors and medical experts to be making decisions that all too often right now are driven by skewed policies, by outdated means of reimbursement, or by insurance companies. And everybody's families, I think, have experienced this in one way or another. That's the reason we need reform right now.
We're going to take one more commercial break, Mr. President. When we come back, we're going to get into the issue of whether or not in a reform measure there should be government insurance for people, because a lot of people are very uncomfortable with that idea. Prescription for America continues.